This presentation will be organized as follows. After a brief introduction, I will present the material and method, the results, and discussion will conclude this presentation with explanation of the limits of this study. Open cystotomy is the recommended treatment of urolithiasis for several years, but several complications are described for these quite simple techniques. Several minimally invasive procedures are described with some advantages compared to OC for calculi removal. Among these techniques, percutaneous cystoscopy and cystolithotomy has been recently considered as an effective minimally invasive technique for stones removal. But there are limited studies comparing this new procedure with standard open cystotomy. We had three objectives for this study. The first was to retrospectively compare surgical, anesthetic, and hospitalization times between PCCL and OC. The second was to compare complication rates between PCCL and OC. And the third was to describe the technique used for the PCCL group over a 4 years period at a private practice. So, for the material and method, this retrospective study has been done over a 4 years period in one veterinary center in Montreal at the DMV Center. All animals were client-owned who came for PCCL or OC procedures, and medical records of dogs and cats that underwent the PCCL or an OC were reviewed. History, signalement, physical examination, pre-op diagnostic tests, surgical technique, complications, anesthetic, surgical, and hospitalization durations were recorded. For the procedure, the OC were performed as previously described with the conventional methods, and the PCCL procedures was performed by one internist, Dr. Java, and one surgeon, Dr. Mathieu Gatineau, Jérôme Planté, or Jérôme Benamour. For the PCCL procedures, the patients were placed in dorsal recumbency under general anesthesia with the surgical table slightly inclined with the animal's head down, as you can see on these pictures. By positioning the patient this way, the bladder was easier to identify by the surgeon. After a red rubber urethral catheter placed in retrograde manner, sterile saline was slowly infused through the urinary catheter to promote bladder distension and facilitate the localization of the bladder. And after that, here we go, a ventral midline skin incision around 1 centimeter was performed, and after subcutaneous tissue dissection, 1 centimeter abdominal incision was done. 2 stage sutures, as you can see on the video, were placed, on the right and on the left. And after that, the apex of the bladder was grasped with a traumatic forceps, and 1 stage suture was placed in the apex of the bladder. 2 more stage sutures were placed on the left and on the right into the bladder, including the abdominal wall. After that, a stab incision was performed between the stage sutures. A 5 mm laparoscopic treated cannula with a diaphragm was introduced through the stab incision, and multiple flushes were performed through the urethral catheter until the fluids coming out was really clear and no more blood clot or calculi were seen. After that, the bladder was inspected and explored first by a rigid cystoscope, and secondarily a flexible ureteroscope was introduced into the cannula to inspect bladder and urethra. During the exploration of the urethra, the red rubber catheter, as you can see on the video, was removed with multiple flushes. After the final exploration with the flexible ureteroscope, the bladder was closed routinely with 1 or 2 layers as the surgeon preferences, and the abdominal wall was closed routinely. For the skin, 1 crochet stitches was performed, or the surgeon placed surgical glue as his preferences. Regarding the results for the population between January 2014 and February 2018, 91 animals underwent surgery for bladder or urethral cystolysis at the DMV center. All animals meet the inclusion criteria. OC procedures was performed in 40 animals, and 41 animals undergone a PCCL procedure. There was no statistical significant difference regarding age and weight between both groups. Regarding the results, we can note that no significant difference between anesthesia and surgical time was noted between OC and PCCL group. The median anesthesia time was 98 for OC minutes, and 90 minutes for PCCL groups. For the surgical time, the median surgical time for OC was 48.5 minutes, and for the PCCL group, 45 minutes, respectively. The surgical and anesthetic time was not significantly different between both groups, regardless of the number of calculi. We made 2 groups for more than 10 or less than 10 calculi. A significant difference was noted in the hospitalization time between the 2 procedures. The post-operative time was found to be 18 hours shorter for PCCL compared to OC. In the PCCL group, the median hospitalization time was around 12 hours, whereas the median hospitalization time was around 29 hours in the OC group. Finally, when we compare the perioperative complication rates, no PCCL need conversion to OC. In OC group, we had 1 major perioperative complication with 1 patient died because of severe electrolyte disturbances. All other perioperative complications in OC and PCCL group were minor, with 1 complication in each group, and no significant difference was found between the 2 groups regarding the perioperative complication rates. For the postoperative complication rates, we had 2 surgical revisions in OC groups and 1 death. So 3 major complications, and in PCCL group, no revision was needed, but 1 patient had seizures after the procedures. So 1 major complication. All other complications were minor, with urinary tract signs, digestive signs, wound inflammation, and discomfort. In both groups, all minor complications were self-limiting or medically managed and resolved in few days after the procedures. There was no significant difference between the 2 groups regarding postoperative complication rates. If we make a little resume of our results, no significant differences in surgical and anesthetic times were noted between the 2 groups. Hospitalization times were shorter in PCCL groups, and regarding the complication rates, they are low and similar in both groups. It's interesting to note that no conversion was needed in PCCL group, and no calculi were noted after PCCL procedures. The surgical times were similar over the years when we looked during the 4 years period. What we have learned during this study, the incline table allows better bladder visualization and may reduce the surgical time. All copious flushes prior to inserting the scope permit to remove all the smaller calculi and whole blood clot. It permits to avoid bleeding and to control a little hemorrhage in the bladder. It's interesting to note that the surgical time were similar over the years. This data suggests that the internist and the surgeon were already trained and comfortable to perform these procedures. We believe that the combination of board-certified surgeon and internist skills, both comfortable with interventional procedures, is probably the best way to achieve the total surgical and anesthetic time and provide optimal results for the patients. In previous studies, OC was compared to laparoscopic assisted cystoscopy, LAC. The median surgical time of LEC appears to be much longer than the PCCL procedures and much longer than OC. It could be a potential advantage of PCCL over LEC. In previous studies, hospitalization time was similar for LEC in comparison with OC, and it could be another advantage of PCCL that the hospitalization time was clearly shorter in this study. In this study, the PCCL was more expensive than OC as LEC described in previous study. All tips and tricks used in this study improve location of the bladder, make easier stones removal with all abundant flushes, and finally reduce surgical and anesthetic times. No lithotripsy was needed in this study, and all the stones was removed for all cases. In previous study, 3% of procedures requiring lithotripsy. In LEC procedures, incomplete stones removal was described in 6% of dogs. So it's much than described in this study. In the OC group of the present study, one dog had a calculus free in the abdomen, and one patient presented an obstruction 2 days postoperatively, corresponding to 5% of patients with incomplete stones removal. This result is lower than previously described, as some studies revealed that about 14 to 20% of dogs and 20% of cats could have urines visible on postoperative radiographs after an OC. Indeed, the bladder examination during an OC is more difficult than during a PCCL or LEC procedures, and the urethra cannot be evaluated. So, advantages of the PCCL technique is that the bladder examination is easier, bleeding are more controlled, edema and mucosal trauma are limited, and we have a better visualization of the urethra. Maybe it's less painful, but this point was not evaluated during this study, and further studies are needed to conclude on this point. Some potential disadvantages of the PCCL technique is that the material, and we have to know how to do these procedures, and maybe the cost. But when the clients were asked, 71% of owners said that the extra cost worth the benefits. The limits of this study, it's a retrospective study. We had multiple surgeons that did the procedures, but when we look at the data, Mathieu Gatineau and Romain Javard did 93% of PCCL procedures, so this bias is a little bit decreased. Some interns may have done some OC procedures under direct supervision, but this could increase forcefully the anesthetic and surgical times. Some animals in OC group may have stayed in hospital postoperatively without real necessity, but for us, OC tend to be uncomfortable, so warrant extra hospital was done for these animals. If an animal in PCCL group was uncomfortable, we will recommend some extra hospital too. To conclude, this study showed that no matter the number of calculi, the PCCL procedure was effective and no more time consuming than OC. Indeed, no significant differences in anesthetic or surgical time was found between the two groups, and regardless the number of calculi. I would like to thank a lot the SVSTS meeting and in particular Alex for his kindness and his understanding, Dr. Romain Javard for his careful proofreading and strong support, Dr. Julie Le Cavalier, my second author, for her support and her help, all other co-authors of these studies, and Dr. Pierre-Maître and Stéphane Bureau, my two mentors, for their read-throughs. I will be happy to entertain your questions if you have some, and if you are not too tired by my terrible French accent.
Meet Ray. Ray was an 8-year-old male intact Labrador retriever. He had no major medical history and no history of any prior surgeries. He was up to date on his vaccines and preventatives. And an important lifestyle bit of his history was that he had free access to a fenced-in backyard, and his owners had had him since he was young, so really hadn't ever been able to watch his urination habits very closely. His medical history started several months prior to coming into UGA when he was boarding with his referring veterinarian, and the staff there noted that he had gross hematuria. They got permission to do a CBC, chemistry panel, and thyroid panel, which were all unremarkable, and then took urine via cystocentesis and found that his urine-specific gravity was low at about 1002. He had pretty marked pyuria and hematuria, and they suspected bacteria on the dipstick, though no culture was performed to confirm it. They started Ray on ciprofloxacin at 18.5 mg per kg every 12 hours, and his hematuria did resolve. Fast forward to about 5 months later, again, while he was boarding with the same referring veterinarian, they noticed that he had gross hematuria. At this time, a urinalysis was not repeated, and a referral was made after abdominal radiographs that were taken had them concerned that Ray may have cancer in his abdomen. Interestingly, while he was there boarding, his hematuria did resolve without treatment. So these are the radiographs that the referring veterinarian took, and on the right side of the screen we have the VD view, and then on the left side of the screen a right lateral view. And what we saw on these radiographs was this very large, well-defined structure in the right side of the abdomen that was pushing all of his other organs over to the left side of the abdomen. On the lateral view, we did notice that we could see his left kidney quite well. It seemed pretty normal in shape and margination. And then we also noticed that he did have a little bit of prostatomegaly, but felt this was probably consistent with his age and reproductive status. So when Ray came to us after looking at these radiographs, we repeated his physical examination, found that his body condition score was good. He was bright and alert. His abdomen was actually really soft and non-painful. You could feel that there was an enlarged structure within his abdomen. We were unable to palpate his prostate on rectal examination, but found no other abnormalities on his physical exam. We repeated his CBC and chemistry panel, which were both still normal. Also repeated a urinalysis and found that his USG was 1010 with us. He had less than 10 red blood cells per high power field, rare white blood cells, and we did not see any bacteria, which was confirmed with a negative urine culture. So given all of this information, we decided that the best step to take next was to perform an abdominal CT. So here we have several post-contrast images of Ray's abdomen. And so we'll start with this transverse image in the top left of the screen. So here we can see that we have the right ureter, which is dilated and entering the urinary bladder in an intramural fashion. We also can see the entry of the left ureter in a normal location, not running intramurally. And when you scrolled through the CT, you could see contrast streaming out of that left ureter into the urinary bladder. On this dorsal image, it fits a lot with what we were seeing on our radiographs. So you can see that this right kidney is severely hydronephrotic. The right proximal ureter is also incredibly dilated and filled with urine. And then you could follow this distal ureter along a really tortuous path and ultimately found that it was entering the urinary bladder in this intramural location. And when you followed this out on the CT scan, it seemed to be terminating at the pre-prostatic urethra. And then the sagittal image is showing the same thing, but I think really does highlight, you don't see very much contrast uptake in this kidney at all. You can see a little bit pooling in the renal pelvis here, but really we were quite concerned based on the imaging that this kidney probably did not have very much function anymore at this point. And again, can just see in this image how hydronephrotic and how enlarged this ureter was. So given this information, we did talk a little bit with our internal medicine team about whether or not single kidney GFR would be worth it in Ray. We decided that given how severe his hydronephrosis and hydroureter were, coupled with the fact that he had normal kidney values despite his low USG of unknown etiology, we decided it probably wasn't worth doing in him, and so planned to move forward with an exploratory laparotomy. So in surgery, this is what we saw. To orient you in this image, at the top of the screen, we have cranial, and the bottom of the screen is caudal. And just below the hand here, you can see the outline of this right kidney, which, you know, kind of hard to tell from this image, but it of course was very, very enlarged, and you could tell that it was just sort of a sac of urine, not normal architecture at all. And then here we have this incredibly enlarged proximal ureter. And the retroperitoneum had a good bit larger blood vessels than we typically would see. This image is trying to follow out the more distal aspect of this right ureter, so still very dilated, just not nearly as impressive as the proximal ureter, and you can see that it kind of follows this tortuous path and gets kind of kinked up, so it makes sense why that proximal ureter is so much more dilated. This is a little video that we were able to get in surgery, and excuse the ventilator causing some motion here, but what we wanted to point out here was in the distal ureter, where it is more tortuous but less dilated, there actually still was a good bit of peristalsis still. So we thought that was kind of a fun thing to be able to capture some video of. Never saw any peristalsis up in this more proximal ureter, which I think is expected. But ultimately, given the severity of this hydronephrosis and hydroureter, we did decide just to go ahead and move forward with a ureteronephrectomy in Ray. This is what the kidney looked like when we took it out. So as expected, the kidney was quite enlarged, but also just sort of a sac. You could fit your hand inside of it if you wanted to. Proximal ureter, as expected, was really, really enlarged, but really liked that you could see pretty defined where this ureter actually kinked off, leading into this more distal, less dilated ureter. We did submit this kidney and ureter for histopathology and found that the medulla had been diffusely replaced by collagen. As expected, the renal cortex was almost completely atrophied, and there was diffuse interstitial fibrosis and nephritis throughout the kidney. This is an image of the kidney taken by the pathologist, and you can see just how impressively enlarged this renal pelvis was. And then in the ureter itself, they did find multifocal uroepithelial erosions within that really, really dilated portion of the ureter. So our theory is that perhaps the hematuria was coming from these erosions, though we're not really 100% sure about that. And they also found multifocal uroepithelial hyperplasia. Post-operatively, Ray fortunately did great. We maintained him on IV fluids overnight and then rechecked his kidney values serially as we decreased his IV fluid rate. And ultimately, after discontinuation of the fluids, his kidney values remained static, and so he was able to be discharged about 36 hours after surgery. We did not repeat a urinalysis while he was in the hospital since he had been on the IV fluids. We were able to contact both the owner and the veterinarian about a year after surgery, and both reported that Ray was doing great. He had recently been in for an annual examination for his vaccines, and no problems were reported, no history of polyuria, polydipsia, or hematuria since his surgery. Unfortunately, they did not repeat his urinalysis or blood work, so we don't really know what his kidney values or urine-specific gravity are doing, but presumably doing well since he seems to be doing so great. Just a few discussion points with this case. Of course, we know that in dogs, ectopic ureters tend to be intramural most of the time, much more commonly diagnosed in female dogs. There is a small study looking at ectopic ureters in male dogs, just about 16 of them. And even though they were males, incontinence was still the most common presenting complaint. A little over 80% of the dogs in that study presented for incontinence. About 90% of the dogs also presented before they were 2 years old, which, fits with that history of incontinence, and is of course why those dogs probably showed up a lot earlier than Ray did. Hematuria was not seen in any of those dogs. So this case, maybe highlights that it might be more common for more male dogs to be running around with ectopic ureters, and we just may never know because they aren't incontinent and maybe don't have any signs such as hematuria to point us in that direction. But especially given that Ray was kind of referred over with an expected really poor prognosis because of cancer, that was suspected on his radiographs, I think keeping in mind that maybe it could just be a late diagnosed ectopic ureter is a good thing. We did, of course, do a ureteronephrectomy in Ray and decided to do that just because of the severity of his hydronephrosis and hydroureter. We were worried that if we left those really dilated tissues in him, even if we rerouted the more distal ureter, that he would still have hematuria potentially, as well as be at a higher risk for recurrent infections. In humans, they have actually looked at biopsies of ureters that have been had severe hydroureter for various reasons, and have actually proven that the smooth muscle does not have normal contractile function. So probably similar to what we see with detrusor atony in the urinary bladder. Happens in the ureter potentially as well. So we were really worried that that would just continue to be a problem in this really dilated ureter. But of course, in most cases, we would not have treated an ectopic ureter with a nephrectomy. We would have rerouted it or done laser ablation. And possibly those would have been options if Ray had been diagnosed earlier in life, but he didn't have signs to kind of point him to the veterinarian to get him there sooner. With that, I will take any questions that you guys have, or would love to hear if anybody would have approached this case differently. And thank you guys so much for letting me share this case with you today.
The perineal urethrostomy, or PU, is a surgical procedure that involves amputation of the narrow penile urethra to create a direct opening of perineal skin to the wider pelvic urethra. The goal of the procedure is to reduce the risk of potentially fatal urethral obstructions. The Wilson technique, described in 1971, is the most commonly used today and was originally performed in sternal recumbency. Dorsal recumbency was first described by Kagan in 1976. Surgeons who prefer the dorsal position believe it's more ergonomic for the surgeon and negates the need for repositioning of the patient if a concurrent cystotomy is to be performed. It minimizes pressure on the diaphragm by the abdominal viscera, and it avoids cranial movement of the urinary bladder that could inadequately expose the pelvic portion of the urethra. Literature comparing the two positions is limited. A 2018 study by Slunsky et al. In the Journal of Feline Medicine and Surgery compared the diameter of the vertebral canal with cat cadavers placed in sternal versus dorsal recumbency. This was in order to investigate potential causes of neurologic deficits associated with the procedure, such as decreased intraurethral pressure leading to UTIs and fecal or urinary incontinence. The investigators found there was a significantly larger reduction in the diameter of the lumbosacral and sacrococcygeal vertebral segments when cats were placed in sternal positioning. Due to this reduction having the potential to cause iatrogenic nerve injury, they concluded that dorsal positioning was superior from an anatomic perspective. These images from the article show the positioning for dorsal recumbency on the left, with the pelvic limbs extended cranially, and sternal recumbency in the middle shows how the tail is secured cranially and the legs are suspended off the edge of the table. This year, also in the Journal of Feline Medicine and Surgery, Watson et al. Published a case series investigating complications associated with PUs performed in dorsal recumbency. The authors found no major complications, which they defined as a need for revision or for euthanasia, and they concluded that the dorsal positioning may improve visualization, which would allow for efficient dissection and improved apposition. To our knowledge, optimal patient position has not yet been evaluated. Therefore, the primary aim of this retrospective study was to compare the durations of surgery and anesthesia time and the likelihoods of short and long-term postoperative complications between groups of cats in which PU was performed in sternal or dorsal recumbency. A secondary aim was to compare the complication rates associated with various suture materials and skin closure patterns. We hypothesized that patient position would be associated with durations of surgery and anesthesia in situations in which a cystotomy was performed concurrently. We hypothesized that the two patient positions would have similar likelihoods of postoperative complications, and complication rates would not significantly differ when comparing different skin closure patterns and suture materials. For our methods, 7 referral hospitals collected data from a 10-year period. Patient details included signalment, presenting complaint, and indication for the procedure. Procedural details included positioning, suture material, closure method, length of surgery and anesthesia, and any concurrent procedures performed. And postoperative details included the occurrence of short and long-term complications, with short-term complications defined as those occurring less than 2 weeks postoperatively, and long-term complications considered more than 2 weeks postoperatively. For statistical analysis, comparisons were evaluated using appropriate univariate analysis, including Fisher's exact test, chi-square, or the Wilcoxon rank sum test. To determine possible confounding factors associated with the 4 variables of primary interest, 18 independent variables were evaluated in a multivariate regression analysis. Only those factors with a p-value of less than 0.2 were included in the final model, and a p-value of less than 0.05 was considered significant. For our results, we had a total of 247 cases included in the study. For patient details, there was no difference in patient age, body weight, sex, or breed between the groups. The most common presenting complaints were urethral obstruction, straining or frequently posturing to urinate, non-specific abnormal behavior or ADR, plaqueuria, and vocalization. Of all presenting complaints, significantly more cats that were straining or frequently posturing to urinate were positioned in sternal recumbency for their perineal urethrostomy, and all cats had a urethral that presented with urethral tears or ruptures were positioned in dorsal recumbency. Approximately 2/3 of cases were performed in sternal recumbency, and 3.7% of these cats had to be repositioned to dorsal recumbency, either due to the need for a cystotomy or a pre-pubic urethrostomy. Those with unknown positioning were only used for analysis of closure methods and suture materials. 10.1% of cases had a cystotomy performed under the same anesthetic event, and the vast majority of these had their PU performed in dorsal recumbency as well. This graph compares the surgery and anesthesia times. On the left are cases that only had a PU performed, and on the right are cases in which a cystotomy was performed in addition to the PU. Gray bars represent sternally positioned cases, and dorsal cases are found in black. There was no significant difference in surgery anesthesia time between any of the groups, with all p-values being 0.46 or higher. In the multivariate regression model, patient position had no association with duration of surgery or anesthesia. As expected, concurrent cystotomy was associated with a 46.6-minute increase in the duration of surgery and a 48.9-minute increase in the duration of anesthesia. Each subsequent year of surgery over the study period was associated with a 1.4-minute increase in surgery and a 2.5-minute increase in the duration of anesthesia. In other words, surgery and anesthesia time were a little longer each year. A presenting complaint of urethral tear or rupture was associated with a 43.9-minute decrease in the duration of anesthesia. This graph illustrates the frequency of the overall and the most common short-term complications reported. All cases combined are indicated by the striped bars. Sternal cases are again in gray, and dorsal are again in black. The overall short-term complication rate for all cases was 47.3%. The most commonly reported short-term complications were recurrence of signs of feline lower urinary tract disease or fluted, hematuria, which we considered separately, and inflammation, which included peristomal irritation or granulation tissue formation. This graph displays the occurrence of long-term complications of all cases, as well as those placed in sternal and dorsal recumbency. The overall rate for all cases was 27.2%. Urinary tract infections, hematuria, and recurrent urolithiasis were the most commonly reported long-term complications. In the multivariate regression model, patient position was not associated with the likelihood of short or long-term complications. A presenting complaint of vocalization was associated with an increased likelihood of long-term complications. Each subsequent year of surgery was associated with a 10% decrease in the likelihood of long-term complications, meaning long-term complications were less likely over time. For our secondary objective, a continuous suture pattern was associated with more hematuria in both the short and long term, as well as recurrent fluted signs in the short term. Absorbable material was associated with more signs of fluted in the short term and more urinary tract infections in the long term. There was no difference found in the likelihood of complications between suture sites groups. We were incorrect in our hypothesis that position would be associated with surgery and anesthesia times if a cystotomy was performed under the same anesthetic event. We attribute this lack of association to pre-planning by the surgeon and surgery team, which allowed for an efficient change in recumbency. We also attribute pre-planning to our finding that all cats with a presenting complaint of urethral tear or rupture were placed in dorsal recumbency and had a significantly reduced duration of anesthesia. We believe dorsal recumbency was selected in order for surgeons to quickly convert to a prepubic location for their urethrostomy, or in case a cystotomy was needed in order to pass a urinary catheter in a normograde direction. Importantly, patient position was not associated with the likelihood of postoperative complications in the present study. Our findings therefore do not support previous conclusions that dorsal positioning may be associated with less iatrogenic nerve injury. Specifically, we failed to find a significant difference between the groups regarding conditions that may be attributable to nerve injury, such as urinary tract infections and incontinence. Likewise, we failed to find a difference in the occurrence of major complications, such as the need for surgical revision. A presenting complaint of vocalization was significantly associated with the likelihood of long-term complications. A possible explanation for this association is the variation among cats in their expression of discomfort or stress. Many of the long-term complications that we looked at in our study are associated with some form of discomfort, and it's possible that some cats that are accustomed to communicating with their owners in this way are more likely to alert their owners to such long-term complications. Additionally, each subsequent year of surgery over the study period was associated with a decreased likelihood of long-term complications. This may be because of improved understanding of fluid over the study period, as well as implementation of medical and behavioral strategies in the long-term management for these affected cats. For our secondary objective, we identified that a simple continuous suture pattern was associated with hematuria and recurrence of signs of fluted in the short term, and with hematuria in the long term. To our knowledge, a comparison of suture patterns for skin closure for PU in cats has not been reported previously. Additionally, we identified that absorbable suture material was associated with signs of fluted in the short term and with urinary tract infections in the long term. The latter finding is inconsistent with the findings of Agrodnia et al., who reported no differences in complication rates between PU procedures using absorbable or non-absorbable materials. A difference may have been noted in our study because of the larger sample size. However, confounding variables may also account for this difference. Limitations of the present study include those inherent to retrospective designs, including incomplete records. The distribution of cats and their associated position for PU differed significantly between the 7 study sites, and this difference could have influenced our findings. We did not perform a priority sample size calculation to ensure sufficient cats were included to minimize the chance of type 2 error. Therefore, the study may have had insufficient power to actually identify significant differences. And finally, multivariate regression analysis was not performed to identify any association between suture pattern or type and the likelihoods of short and long-term complications due to the large number of confounding variables. Given the failure to find a difference in surgical and anesthetic times and the likelihoods of short and long-term complications, we conclude that logistic considerations such as the need for cystotomy and personal preference may continue to guide veterinarians when positioning cats for perineal urethrostomy. Here is a list of references that were used in the preparation of this abstract. And at this time, I'd be happy to answer any questions.
The most common source of urinary tract implants are purposefully placed indwelling implants. These include urinary catheters, cystostomy tubes, ureteral stents, and urethral stents. In the upper right hand is a radiograph of a dog who was hit by a car and required a urinary catheter. Below is a radiograph of the same dog taken after the patient chewed the distal portion of the catheter, leading to inadvertent retention of the catheter within the bladder. Mechanisms of retrieving retained foreign bodies include surgical retrieval, which has inherent morbidity, requires general anesthesia, and has a certain risk of complication. Endoscopic retrieval is a minimally invasive method, although limitations of cystoscopy in small animals include availability of equipment and patient size. As access to equipment and imaging technologies have advanced in veterinary medicine, novel, minimally invasive techniques and options have become available. As such, some cases of urinary tract foreign bodies or malpositioned implants may be better treated by minimally invasive treatment options, such as fluoroscopic-guided endovascular snare removal. The endovascular snare system has been reported for retrieval of intravascular foreign bodies in veterinary medicine. A single loop rather than multi-loop snare was used, and this procedure was successfully performed in all patients that it was attempted in. Despite this report, the use of the endovascular snare system has not been reported for use in other body systems in veterinary medicine, such as the genitourinary tract. The objectives were to report the removal or repositioning of urinary tract medical implants in dogs and cats using an endovascular snare system, or ESS, under fluoroscopic guidance, including procedural utility and complications. A medical records review was performed to identify dogs and cats that underwent removal or repositioning of urinary tract foreign bodies or implants using an ESS with fluoroscopic guidance at UC Davis from 2013 to 2019. Information collected from the medical record included signalment, the reason for ESS use, comorbidities, procedural details, complications, and outcomes. Procedures were further divided into 4 categories, which will be reviewed. These included transurethral removal of urinary tract foreign bodies, meaning catheters were passed from the urethra into the working space of the bladder. Second was transurethral stent repositioning, where instruments were passed through the urethra to work within the bladder and the distal ureter. Transnephric stent retrieval included the passage of instruments through the renal cortex and into the pelvis, the renal pelvis and proximal ureter. Final procedure was cystoscopic assisted stent retrieval, in which instruments were passed into the bladder through the urethra and into the distal ureter for manipulation of retained or malpositioned stents. For the purpose of this report, the term urinary tract foreign body refers to all implants, including ureteral stents and urinary catheters. The main players of these procedures include hydrophilic guide wires, pictured in A and B, which provide wire access to luminal structures, including the urethra, bladder, ureters, and renal pelvis, over which additional catheters can be guided. Pictured in C is an introducer sheath and dilator. The dilator is tapered to the guide wire and allows passive dilation of structures that the sheath is intended to rest within. Having the sheath in place allows for repetitive passage of wires and catheters while minimizing trauma to surrounding structures. Pictured in D is a multi-loop snare wire, which is within the snare catheter. The snare wire has loops of different widths to allow for expanded versatility of use. For transurethral removal of urinary tract foreign bodies, the patient is in lateral recumbency. For orientation, in yellow is the outline of the bladder and urethra, and in red is the retained foreign body, which is also labeled with an asterisk. In A is a guide wire noted by a cross, which is passed through the urethra and into the bladder. In B, an introducer sheath and dilator is passed over the guide wire and seated within the urethra. The snare catheter, denoted by the arrow, is passed over the guide wire through the sheath and seated within the bladder. The video in C depicts a multi-looped snare passed retrograde through the snare catheter with the foreign body subsequently engaged and retrieved. For transurethral stent repositioning, the patient is in lateral recumbency. Briefly, the bladder and urethra are outlined in yellow, the ureter is outlined in blue, and the stent is outlined by red. A guide wire is placed open or percutaneously, spanning from the kidney through the ureter and into the bladder and out the urethra. A second guide wire and introducer sheath and dilator are passed into the distal ureter. The snare wire is passed and deployed into the ureter. Once engaged with the distal pigtail of the ureteral stent, the stent is repositioned into the bladder from the ureter. This is pictured on the right. For transnephrous stent retrieval, the patient is in dorsal recumbency. Outlined in yellow is the kidney and proximal ureter, and in red is the ureteral stent. A transnephric catheter is identified with an asterisk, and the cranial and caudal margins are labeled. Pictured in A is a nephropyelogram performed through a catheter inserted through the renal cortex. Pictured in B is a guide wire passed into the renal pelvis over which an introducer, sheath, and dilator are introduced. In C, a snare catheter is introduced over the guide wire through the sheath into the renal pelvis. The guide wire is removed and a snare wire introduced through the catheter and deployed within the renal pelvis to grasp the proximal loop of the ureteral stent. In D is an intraoperative video of transnephric stent retrieval with the left kidney denoted by an asterisk. For cystoscopic assisted ureteral stent retrieval, the cystoscope is introduced into the urethra and bladder to visualize the ureteral orifice. A hydrophilic guide wire is passed into the ureter under cystoscopic visualization and coiled within the renal pelvis. The cystoscope is removed and a snare catheter is passed over the guide wire into the ureter under fluoroscopic guidance. After removal of the guide wire, a multi-loop snare wire is passed into the catheter and deployed in the region of the ureteral stent, which is then engaged with the snare wire. To the right is a picture of a snare wire and catheter engaging a distal pigtail of a ureteral stent. The arrowhead is pointing to the snare catheter, an arrow pointing to the snare wire. In total, 17 patients undergoing 18 procedures met inclusion criteria. For dogs, median weight was 25 kilograms and median age was 7 years. For cats, median weight was 5 kilograms and median age was 9. Patients were grouped into 4 categories based on the procedure that was performed by the snare system. 12 patients underwent transurethral removal of urinary tract foreign bodies. 3 underwent transnephric stent retrieval. 2 underwent transurethral stent repositioning. And 1 underwent cystoscopic assisted stent retrieval. It should be noted that the ESS device was not used in any male cats. 6 male castrated and 1 male intact dog underwent transurethral retrieval of retained urinary catheter fragments. 1 male castrated dog, 2 female spayed dogs, and 2 female spayed cats had removal of previously placed ureteral stents due to infection, malpositioning, migration of the implant, clinical signs attributed to the implant, or as part of a planned procedure after temporary stent placement during renal sclerotherapy. Devices utilized included snares with loop diameters of 12 to 20 millimeters, 18 to 30 millimeters, and 6 to 10 millimeters. For one dog in which a retained urinary catheter was being removed, the catheter slipped out of the ESS device at the pelvic flexure and had to be retrieved from within the urethra a second time. No patient required conversion to a more invasive approach. Median procedural duration was 30 minutes. It should be noted that sedation was used in 3 of the 7 patients for retrieval of retained urinary catheters. 3 animals underwent transnephric stent retrieval of a malpositioned or migrated stent or fragmented stent in 1 patient each. There was 1 each of the 12 to 20 millimeter, 6 to 10 millimeter, and 2 to 4 millimeter snare wires. No procedure complications were reported, and procedure duration was not reported as well. 1 male castrated and 1 female spayed dog underwent transurethral stent repositioning due to intraoperative malpositioning of a ureteral stent. An 18 to 30 millimeter and 12 to 20 millimeter snare wires each were used. No procedural complications were reported, and procedure duration was not reported as this was performed as a part of a larger procedure. In 1 female spayed dog, cystoscopic assisted stent retrieval was performed for retrieval of a ureteral stent that had migrated into the renal pelvis. A 12 to 20 millimeter snare device was used. No procedural complications were reported, and procedure duration was 30 minutes. Based on our findings, distinct advantages of this system include the minimally invasive nature of the procedure. Natural orifice or percutaneous introduction of this system into the genitourinary tract, as reported, limits morbidity to the patient and theoretically would improve quality of recovery, although this was not evaluated in this study. We recognize the system was used in an open laparotomy in 1 case, although the success of this system in retrieving foreign bodies from the renal pelvis prevented more morbid procedures, which may have included nephrotomy. The range of sizes from 2 to 4 millimeter to 27 to 45 millimeter snare wires and the 3.2 to 7 French snare catheters allowed for use in cats and small and large breed dogs. Additionally, the working space of the renal pelvis and bladder are vastly different, and both were successfully accessed, demonstrating the versatility of this system. Finally, a portion of these procedures were performed as an adjunct to a primary procedure or surgery, thereby requiring general anesthesia. But a portion undergoing urinary catheter foreign body retrieval were able to be sedated rather than anesthetized, potentially allowing for improved efficiency of procedure and also may be beneficial financially. Limitations of this procedure include the necessity for specialized equipment. A fluoroscopy unit is required, as well as various wires, catheters, and introducer systems to make this feasible. Additionally, expertise with the equipment is required to continue to perform these successfully and efficiently. Fluoroscopic guidance necessitates patient and clinician exposure to radiation. Therefore, using fluoroscopy judiciously while wearing appropriate protective equipment is essential. Finally, small case numbers may have allowed us to underappreciate potential short and long-term complications associated with this procedure, and additional cases are required for further assessment. This report is the first describing the use of the endovascular snare system in the genitourinary tract in dogs and cats. Within this cohort, transurethral and transnephric manipulation or retrieval of medical implants from the renal pelvis, ureter, bladder, or urethra using a fluoroscopic guided multi-loop snare wire and catheter system is feasible and safe. This technique may avoid additional cost, morbidity, or time incurred by open or endoscopic approaches. Thank you to UC Davis for supporting our research, as well as my co-investigators, and Society of Veterinary Soft Tissue Surgery for allowing us to present our findings. And I am happy to take any questions at this time.
So to start, why are surgical imaging modalities important to research and improve upon? For one, veterinary educators today are up against growing class sizes, making individual teaching moments a less frequent occasion. We have to adapt and use other modalities to overcome these limitations and ensure that our veterinary students learn the surgical basics and procedures that are expected of them upon graduation. We owe it to our students to avoid situations highlighted in these photos, where the students are unable to learn meaningfully in the crowded ORs. Some of the benefits of video-based learning include on-demand access, the ability to practice surgical skills while watching, thus freeing lab time for application of learned skills, and live streaming of video in the crowded ORs. Such benefits over traditional methods of learning are likely responsible for the improved surgical performance and retention observed with video-based learning. Specifically, self-directed video-based learning and practice has been demonstrated to be the most influential modality for surgical training, as demonstrated by Shippey and Langbeck. Given the research supporting the value of video-based learning, critical evaluation of the quality of different video capture methods is imperative. In the video on the left, video capture of a thoracotomy by a built-in OR light camera is frequently obstructed by the surgeon's head, and intricate details of the surgery are difficult to appreciate. Similar limitations are also encountered with headband use of cameras. In contrast, in the video on the right, you can see how easy it is to load a non-sterile camera into a handheld camera case. Subsequent operation of the handheld action camera directly by the surgeon demonstrates superior visualization of the surgical procedure. Due to such benefits, this study sought to investigate whether loading an operation of non-sterile action cameras into their sterile cases is possible without contamination of the surgical field. We hypothesized that first, different cameras can be repeatedly sterilized with ethylene oxide. Secondly, that non-sterile cameras can be safely loaded into their respective sterile cases without contamination. Thirdly, that the sterile cases will maintain a sterile barrier between the sterile surgeon and non-sterile camera for the duration of the surgery. 4 cameras and their associated cases were purchased based on varying price points. The Johto smartphone case accommodates both smartphones and iPhones. Additionally, an inoculum containing 3 common pathogenic bacteria at 10 to the 5th colony-forming units per milliliter was made to provide a more rigorous test of sterilization from synergy of their virulence factors. To start, all 4 cases, as represented by the cameras in the diagram, were inoculated with the pathogenic bacteria. It's important to note that the cases themselves were inoculated and not the cameras. Each case was then dipped into a separate container of sterile TSB broth to confirm bacterial inoculation. The TSB broth was then incubated at 37.8 degrees Celsius for 24 hours and then plated on blood agar plates, which were also incubated for 24 hours. All cases were then sterilized using ethylene oxide. In the operating room, a sterile investigator cultured all cases following ethylene oxide sterilization to confirm sterility. A non-sterile investigator then dropped the non-sterile camera into the sterile case, and an immediate post-loading culture was obtained. The sterile investigator's outermost pair of gloves was removed before each camera was operated for 1 hour, and the camera's buttons were pushed 20 times. Following culture at the 1 hour time point, the camera was operated for another hour before obtaining the final case culture at the 2 hour time point. Camera operation served to test the ability of the case to function as a sterile barrier in the face of heat generation and pushing of the buttons. Following 2 hours, the cameras were then removed from their cases and swapped. A total of 4 rounds were completed. 3 standard rounds where the cameras were decontaminated with Oxivir wipes prior to loading, and a final challenge round in which the cameras were inoculated and not decontaminated. All TSB and blood agar plates were incubated as previously described. All post-inoculation cultures were positive, while all post-ethylene oxide samples did not have any bacterial growth, indicating that ethylene oxide gas sterilization is a safe and effective method of sterilization of these cases, and the cases can withstand repeated sterilization. Of the 48 case cultures obtained in the OR during the standard rounds, or rounds 1 through 3, bacterial growth was absent in 43 out of 48, or 90% of the samples, with 5 of the samples, or 10%, growing either non-hemolytic Staphylococcus or a gram-negative contaminant such as Micrococcus. Swabs of the cameras in rounds 1 through 3 revealed no growth. Thus, the bacterial growth that was detected in 5 out of 48 of the cases in rounds 1 through 3 was not due to a failure of the cases to maintain a sterile barrier. However, the absence of bacterial growth on the cameras impaired our ability to determine whether the non-sterile cameras could be safely loaded into the sterile cases. Thus, the challenge round was completed, in which the cameras were massively contaminated to provide a more rigorous test of the loading process. Pathogenic bacterial growth, consistent with at least one of the bacteria in the inoculum, was consistently isolated from the GoPro case at all post-loading time points, but only at the post-loading time point for the Sony case. An open and closed container of sterile TSB broth was also present in the OR at the time of data collection to serve as controls for environmental contaminants and broth sterility. 50% of the open containers were positive for non-hemolytic Staphylococcus, a non-pathogenic environmental contaminant. This may explain the source of contamination noted on the previous slide. So in summary, camera disinfection prior to loading effectively eliminated all positive camera cultures. There was equal performance of all cases if cameras were disinfected prior to loading into the sterile case. Despite 5 out of 48 of the cultures being positive, all were consistent with non-pathogenic environmental contaminants. However, there was varied performance of all cases if cameras were massively contaminated and not disinfected prior to loading into the sterile case. GoPro was the only case that demonstrated consistent pathogenic bacterial growth at all post-loading time points. The bacteriologic results of this study raise several questions. First, GoPro was the only case to consistently grow pathogenic bacteria, and only in the face of massive contamination of the camera. Unlike the other cameras, the GoPro was the most challenging camera to load, as demonstrated in this video, and is likely the source of case contamination. Secondly, E. coli was cultured from the Sony case solely at the post-loading time point in the challenge round. Since the sterile investigator changed gloves after the post-loading culture, accidental glove contamination during loading is the most likely cause of this positive culture. However, minor contamination of the case itself that was not significant enough to be detected at subsequent time points cannot be ruled out. Third, both non-hemolytic Staphylococcus and gram-negative contaminants like Micrococcus were cultured at several time points in both standard and challenge rounds. These non-pathogenic bacteria have repeatedly been demonstrated to be the most common contaminants in upwards of 81% of ORs and 45% of microbiology labs. Thus, the non-pathogenic bacterial growth could have been from airborne environmental contamination of the TSB broth, as supported by 50% of the open control containers being positive, contamination during plating of the TSB broth in the microbiology lab, or due to an undetected break in the sterility of the sterile operator. Specifically, glove puncture rates are reported to be anywhere between 10 and 26%, with 58% of the surgeon's hands still having detectable bacteria following scrubbing. So if we take this information and revisit the hypotheses, For the first hypothesis, all of the cases can be safely and repeatedly sterilized, as all post-inoculation cultures were positive for the inoculated bacteria, and all post-ethylene oxide cultures were negative. For the second hypothesis, all non-sterile cameras can be safely loaded into the sterile cases if cameras are disinfected prior. This is not true for GoPro in the face of massive contamination. For the third hypothesis, we can conclude that the Sony, Polaroid, and Giotto cases can all serve as a sterile barrier due to the lack of consistent pathogenic bacterial growth. However, we cannot conclude this for the GoPro case, although the authors believe that contamination of the GoPro case during loading is more likely since GoPro performed equally to all of the other cases in the standard rounds. Major limitations of this study include the failure to evaluate for the presence of microorganisms other than bacteria, as well as the inability to immerse the cameras directly in enrichment broth, which has been shown to be more sensitive than swabs alone. Additionally, this was a mock procedure. In a clinical case, the presence of bodily fluids or operation for longer than 2 hours may lead to different results. In conclusion, in the clinical setting, the cameras would not be massively contaminated. Rather, their care and use would more closely resemble how they were handled in rounds 1 through 3. Therefore, using the protocol followed in rounds 1 through 3, we can conclude that all cases are safe for use for image acquisition. This protocol includes disinfecting the camera with Oxivir and having the non-sterile assistant wear sterile gloves during loading. Secondly, having the sterile operator remove their outermost pair of gloves after loading. And finally, administering perioperative antibiotics for common airborne and skin contaminants. We hope this information will be helpful for use in clinics, especially with the transition to online clinical education in response to current events. For an appendix with the recommended protocol for safe sterile camera use in the OR, you can scan this QR code or email me. I would like to thank all of you for coming to my presentation, as well as the Society of Veterinary Soft Tissue Surgery for giving me the opportunity to present my work. Additionally, I would like to thank Dr. Alex Fox Alvarez for all of his guidance and mentorship with this project. At this time, I would like to take any questions.